don't know his exact age, but he's mid 60s. He's coming in with right hip and like radiating pain down his posterior thigh and to the lateral outside of the thigh. He he got a total hip replacement back in December, but he never went to therapy because his doctor didn't recommend it. But now he's coming to me with all this hip kind of issues. I did the evaluation on him, and it seemed like a lot of his symptoms were coming from his lumbar spine, radiating down into the hip, the upper leg. But I think it's a little bit more complicated than that because of those radiating symptoms, but also just based off of the range of motion and mobility issues that he was experiencing in his right hip after the surgery.
And I'm sorry, the right hip was the total hip replacement? It's the same one? That kind of confounds things a little bit, doesn't it?
For sure.
Does he seem like he has the radicular symptoms or the symptoms down the leg all the time?
It's pretty consistent, yeah.
Okay. Yeah, that's what it is that, you know, the pattern like that going below the foot, radiating down to the leg. Yeah. It's, you know, it sounds like you have something going on there. It's probably is more lumbar spine related. It's radicular. Doesn't really seem to change when you do anything, and it's constant. How long has he had the symptom?
It's been like 3 months now.
3 months?
Yeah.
Okay. Was it present there before the hip replacement?
No. And he didn't have these symptoms like directly after the hip replacement. It was, you know, a couple months after the surgery. So
they noticed it?
Yeah.
Okay. What do you think is contributing to it from the hip replacement?
Well, I think the mobility issues from, you know, lack of movement to the hip joint is, you know, because there's no movement there, it's going to put a lot of force up into the lumbar spine. And that's going to lead to a lot of kind of mobility, you know, issues causing more strain, stress to the nerve complex coming into the lumbar spine.
Okay. Get a little advanced here. So that limitation, you think it's going to make his leg longer or shorter?
That is a good question. I think it's going to be shorter because of the replacement itself and mobility kind of issues.
Which one? Because they tend to lack usually with that hip extension, right?
Yeah.
You see a lack of hip extension. Many times internal rotation goes along with it.
Yeah.
And I think hip replacements now are better. I see they come back better now than I did a few years ago. I think it's just techniques and new hip replacements kind of bring that tightness pattern back. But then it often does, it actually can make the leg feel a little bit longer because now they can't kind of stride through that leg and kind of decrease the height. So they tend to may vault over that leg of it. The person making shorter. Now, shortening it, what he can do to shorten the leg is he can pronate his foot. He can be flexed at the knee. And another cue you may see with that too is that if he creates a functionally long leg on that side, is it'll generally cause the innominate to go anterior. And that tends to kind of shorten the leg up. Okay. So you'll get into that in 6 and 7 a bit more on long leg, short leg concepts. But to kind of look at this patient, we have to kind of introduce a little bit of it now, just to get the idea of it. And so with him, you could kind of take a quick look at his foot. And again, it's chicken or the egg, whether he's pronating now to make a shorter leg for a longer leg. So the high arch may actually do that. They'll heighten the leg.
Okay.
So with him, that'd be one thing I would consider if he's still having a mobility issue, because that'll drive the forces up into the back. If he can't extend, he's going to vault a bit over that hip. Anterior innominate may go. And what's that going to do at L5S1?
What's that going to do? Is that what
yeah.
I think, I mean, because there's going to be lack of hip extension, there's going to be some mobility restrictions, and all the extension is going to go into the lumbar spine.
Yeah, it could drive a few things in the lumbar spine. So I like to think about it somewhat in reverse. So, you know, I can extend L5 on S1, or if I'm having an anterior innominate, I'm probably going to be in a relative extended position with the forces if at L5S1. Now, if you don't find this pattern, it's fine. But this would be like kind of my starting mental pattern that I have for somebody that might see like this. Is that, okay, if they have a restricted hip, they're probably vaulting over that leg. So I probably have what's working as a functionally long leg in the gait cycle because of this. to correct for this, I could have basically the nominant's going to maybe flex anterior on the pelvis, which would drive L5S1 into extension.
Mm.
And then do I create a kind of a functional lateral stenosis with that? Is that driving some of the forces I may see in the leg?
Mm.
Might be one thing to kind of consider, especially since he developed this later on.
Mm. Yeah.
You're going to see you're finding mobility restrictions everywhere through his spine, correct?
Yeah, for sure.
So
Yeah.
if I want to look for like maybe what would be the most obvious direct path from the hip replacement to these symptoms, it's probably going to be that with the mobility restriction. Now, occasionally in these individuals, depending how soon they are total hip replacement, if you think about it, sometimes you end up with a functionally long leg anyway, because you have a degenerative hip, which is basically, going from this position here, and as it degenerates, it goes down into here, and then they put a hip replacement in, you're back up here. That in itself can create a functionally long leg. It's great when you can see them ahead of time because you'll see the difference in how it does it, but we don't often see that. So though I wouldn't put a heel lift in many people, these are ones like total knees, total hips are ones that I find that sometimes putting a heel lift in the opposite leg can help abate some of the symptoms for a while because their body's been realigned by the changes in biomechanics.
Gotcha.
He's one you really want to look at and see, does he have kind of a clear, it looks like a leg length discrepancy.
Mm-hmm.
Probably identified a bit of the cause. It could be either he lacks extension, so it's functional, or it could be that now because they lengthened that hip and his body was used to the old hip, it throws him off for a little while.
Mm-hmm.
Does that make sense?
It does, yeah.
Was it an anterior hip, do you know, or a post or a lateral?
That's a good question. I don't know off the top of my head. I can't remember.
Okay. I mean, it might matter too much.
Yeah. Have you noticed a big difference from
the laterals heal, cleaner. I think they cherry pick them a little bit more. And I think you do see a little bit improvement in hip extension depending where they were before. It's always nice to see what their baseline is in their hip range of motion. Mm-hmm. There's all different capsular patterns you'll see. Flexion can be limited. The common one I see the most of them is that internal rotation, extension. I think you see it. We'll talk about seeing that rather early sometimes in individuals. That'll be the first one to kind of be lacking. And then you may find that person you see for 3 years and they get a hip replacement 3 years down the road from the first time you initially saw them. Because you'll get them better, it'll be 8 months. Then you'll see them again, you'll get them better, and it'll be another 8 or 6 months. And you'll get them better, and it'll be 6 months or 3 or 4 months. You see them kind of slowly go down sometimes. Gotcha. So it's a good patient to have. You get a couple extra years out of them, but then by the time they get the X-ray, you'll know when they're done. They'll come in one time and like, you know what, and they'll know this is not like the others. You've kind of taken this hip as far as you can take it.
Have you had multiple patients like that?
Yeah. You see them over the years. They'll talk about the common hips you'll see, and you'll kind of see 2 types, especially when they talk about in hip replacement categories. There's that type, and you'll see that type a lot. Like you'll get them over the hump, and they'll be better and go well. And it'll just be slowly over time, these episodic periods. They'll get this, and you'll get them better. And again, these techniques work well. Whether it's the hip manipulation is a nice one for it. It could just be just because it's not moving well, or just understand the osteokinematics or getting the back to move better. It'll help it so they're not flexing through the hip or just taking the stress off of it. Make sure the ankle's gliding properly, and they can step over their ankle, which can increase the leg length. Mm-hmm. And they'll get better. The other type of hip is the one that goes fast. There'll be that individual where they were playing tennis, in late April, and now their hip is so hot and angry. By the time they get an X-ray, their hip is toast, and they don't know it. They'll basically go down real quick, and then they'll have a hip replacement within 2 months with one episode very quickly. Mm-hmm. There's those 2 types. And, I've seen that for a number of years. And it was in the British Journal of Sports Medicine had a podcast for a hip surgeon out of Australia. And it's exactly what he described. Those are the 2 tips that he sees in that pattern. So depending which one you have or that person's natural tendencies, it'll dictate some of the range of motion. So that's what you got to think about is what's driving forces in the lumbar spine to create, basically what you're getting is a mild grade, neural irritation, it sounds like. Do you say that's what it is?
That's what it seemed like when I initially evaluated him.
Yeah, and it's kind of
him, and he said it's been helping tremendously. And then when we were going through the treatment, he was saying the posterior symptoms he was experiencing was getting better, but then all of a sudden he started having anterior symptoms. So again, it just kind of posed the question in my mind, like, where is that coming from? Is that are the forces now kind of traveling higher up into the lumbar spine, causing more of that, radicular symptoms.
Anterior hip. Okay.
Yeah.
Was his hip range of motion improving?
Yeah, definitely.
Okay. And that's what you got to think about. That's why it's good to remember, okay, anterior versus lateral in approach and that ball levering into the hip. So with that one, I may also consider that's when I say, okay, is this, basically talking about last week, the Mange syndrome, do I have a, thoracolumbar region, which is getting irritated. And now I'm getting referral into the neural network throughout the hip, which can do it. Or am I levering into the anterior hip, which was previously tight?
Yeah.
And now I'm kind of going into that surgical site, and am I getting irritation somewhere in the posterior restraints? As he's walking more, especially if his hip extension starts to improve, it'll decrease the stress on the lumbar spine. As long as the pelvis isn't going with it into a hyper extended position. And then you look at the levering force on the anterior hip. That's a lot of the female anterior hips I'll see. If it's a runner or somebody's athletic, anterior hip pain, many times in that category, they're going to be levering into their anterior hip with a slow cadence or a long stride. That's what I'll see. A female walker who's a little shorter, who walks with a friend, she's the classic one who's overstriding, and she usually comes in with anterior hip pain because of just that long trying to striding motion, just stressing the anterior capsule or labrum. That can occur. He no longer has a labrum per se, so that's not really an issue. But you may want to look at the speed and timing of that.
Yeah,
it's an anterior thing. But I would certainly hedge my bet with the upper lumbar spine, TL junction.
That's what I was thinking. And I don't know, I think he was compensating a lot too, and we did some soft tissue on his quad. And that's, I guess his incision site was more anterior, anterior lateral middle.
Yeah.
So I think that had a factor too, because again, he didn't see a PT before, so I think there was a lot of scar tissue.
Yeah.
That was kind of making things super tight. So he said that so much better after focusing on the anterior portion and his upper lumbar spine. So
good. Yeah, and that makes sense because he wasn't kind of moving through it before, so he could scar up in that pattern or be restricted in that pattern. Yeah. So that would be it.
I thought it was cool. I just wanted to kind of get your thoughts on, if my mindset was kind of in the right direction, kind of when treating him, at least from initial evaluation, because he is getting better. So I think that's obviously what matters most. But see if there's pick your brain, pick your mind a little bit.
I think you're on the right track. And that's not uncommon that as you start getting into these things a little deeper, then you're cleaning up something else along the way because it's either the unintended consequence or now he's opened up in that way.
Yeah.
But that's what I would think is that, you probably got a functionally long leg from this in some way, which again kind of drove forces up into the lumbar region. And that could have been why that lumbar region then broke down pretty quickly because it was probably tenuous to begin with.
Yeah.
And then the anterior stuff kind of makes sense as he starts to change things.
For sure.
What kind of soft tissue work did you do in the front of the hip?
We just did some cross friction, and then I did some ART. Those are the main ones that I focus on.
Yeah, I think the ART techniques are fine for just stretching and some of it is mobilization. I think a lot of ART is desensitization, which I'm okay with too. Yeah, if somebody's immediately better, then I know it's probably desensitization versus me tearing scar tissue. But if it's, again, you get, I think where it may work, it's if you're talking about fascial restriction where he has a scar tissue, which, though we see the tip of it like this, like the tip of my thumb here, and the scar tissue is actually kind of like this as we cut through him. So am I kind of separating out the skin layer from the deeper muscle layer and the muscle sheathing? Yeah. So I think that's a good technique for that and desensitizing. What I commonly do too there, if I find the hip is restricted anteriorly, is I often go up to the upper lumbar or lower thoracic. I'll definitely check that area out next and mobilize it if I'm not ready to manipulate it and stretch it, and then see if that tone changes. So that can help sometimes too to see, okay, do I have a myofascial restriction versus neural tone? Where he's setting. I find that, before I really try to do any kind of psoas work, I always go up there and mobilize upper lumbar spine and see where the dust settles. Because oftentimes you'll find that it'll down ramp that tone and that range will come back. And then I don't have to kind of try and press into him deeply and
it makes sense.
Do as much deeper work.
Typically, with your experience, do you typically just generally do that, or is it based off the assessments, kind of figure that out and then going to the mobilization, or is it just because of experience? You know that
Part of it's just pattern recognition, and then sometimes just getting a feel of, okay, how fast can I move with this person? Is this somebody new who wasn't sent to me? Then I'll go a little slower in how I proceed, and I may set up the TL junction in the later one.
Mm-hmm.
But if I think their symptoms are lumbar, then I'll always go to the TL junction explaining how the muscles interact, and that these muscles down here attach up here. Mm-hmm. So I want to see how they interact. So I may not explain it in the sense of, okay, your psoas is doing this, and here's the neural. So I just kind of work around it a bit so that the lumbar spine and lower thoracic spine makes sense as a functional unit. Mm-hmm. Get in there. So that's just something that I like to play with. I think it works pretty well because for many people, I think it's easy to poke into a groin and find that you have a hot hip or hot psoas. And I guess we first started doing this, I was showing just how I kind of assess the hip for its alignment, and then how that hip ball sits anteriorly. In total hips, you almost always find the hip sitting anteriorly in the socket. It's just kind of its natural resting position with the anterior hip. So you need a little more pressure in the psoas and into those muscle groups. Mm-hmm. With that. So I check hip alignments just by kind of grabbing the trochanter's. The one will always sit a bit anterior to the other. Gotcha. If they have one total hip. If they have two total hips, then they both feel full. Yeah. If you come to the ASIS and go about halfway down the inguinal ligament, drop down a little bit. Those are good ones where they have one hip replacement, is to feel where does that one hip replacement sit versus the other hip. Because that one hip replacement usually does sit anterior. Okay. So they're the good ones to kind of get a sense of, okay, where is my hip actually sitting? So I can kind of work on that. Gotcha. Just that palpation, because hardest thing with palpation is I'm the kind of guy, I need to feel something like 30 times. Yeah. It's not like intuitive in me. I'm not the guy that feels every little thing, but I just do it repetitively all the time on people and normals and everyone. And then that's how I start to develop my kind of pattern recognition and feeling things.
That's interesting that you bring that up, because when we were going through, PT school, all my professors were always just like, oh, you can feel this, right? And it's just like, in my head, I was like, no, not really.
Yeah, you don't feel it.
And through some of the courses that we've had in person, I think the instructors have been great of reassuring us, like, this is, you may be able to feel something here, but this is, what you should be feeling.
Yeah, you look for outliers. It all feels the same. I don't know. And then after a while, it's kind of like, oh, there it is. I see it. Because you felt a bunch. I'm like, this one's not like the last one. And I can kind of back work it in my mind. Right. It's funny, I always say, is if I hung out with Gail for a little bit, I'd always go back and spend the next 3 months practicing and trying to feel what she taught me that time. And it'd be just something that she told me at a bar or somewhere else. Like, oh, shit, I got to look for that. So I spent the next 3 months working on it. And by the time I saw her again, it's like, okay, I've got it. I think I've got what you're talking about now. But it took me 3 months. Yeah. Like he may now have done the one wrist manip for a scaphoid breakdown. I don't know if you did that in your course for the peripheral. Scott did your peripheral course, right? Okay, he may not have done that one. Yeah. Scott had a technique for it. You may have had it.
With the peripheral, we were with Eric at the time.
Yeah.
I think we did it, right?
Yeah, Eric. Yeah, we kind of went through everything, and it's all the same manip, but Eric definitely showed us that one.
Okay, yeah, and the upward manip to unload it. So you think your radial head upward and back?
I think so.
Yeah. Yeah, like that one. Like she told me that, and we were having drinks somewhere at one time. It was funny, was where I was. It was at one of the AM conferences. We were sitting somewhere at like a party, and who Peter O'Sullivan is? He's a big guy that tells you manual therapy's crap and it's all in your head. In Australia. And he's a good publisher, though. Now, he puts a lot of articles out. I always read his stuff. But, yeah, he was sitting there, too, trying to listening in. Gail is pretty unique in that, what she comes up with. But, that's why I don't beat myself up over some of these techniques. And, like, with him, he's a good one to get a sense of what his L5-S1 is doing. How stiff is his spine? You're feeling a 60-year-old spine with a guy with a total hip replacement. Chances are he's levering into that lumbar spine. You probably got a pretty stiff segment there. Yeah. And he's a good one to sense of, okay, this is stiff, but it's not maybe subluxed. Yeah. And that's where you get some spurring that goes around it and some different things. And he probably has some facet spurring that's there. Mm-hmm. That's a little bit of getting into the case that I put up of what we would see with that one. Yeah. Okay. So what else with this? I see Eric's coming on board. We'll get his thoughts on this one as well. Things I would do with this on is, hey Eric.
What's up, guys? Sorry I'm late.
Nah, no problem. check. Chris had a case where we're talking about it's a right total hip. Chris, you tell him the case actually.
Yeah, sure. Mid 60s, he got a right total hip in December. His surgeon did not recommend PT at the time. After a couple, I think it was 2 months, he started experiencing some right hip posterior going down into the thigh pain and lateral thigh pain. So we were just kind of discussing. I started seeing him 5 months after surgery, so he had it for like 3 months, progressively getting worse. We were just kind of talking about what was going on, whether it was coming from the total hip or because of the lack of mobility and strength exercises, if it was kind of working up its way up to the lumbar spine. So we kind of just kind of talked that.
Yeah, I mean, with total replacement stuff, you kind of have those two options. Whether it's the replacement itself, some problem with that. You could have a appliance that's loosening, something of that nature. It's probably at 5 months, it's probably too soon for any of the like metal to start wearing down. You can get some like metal toxicity from that sort of thing. And the other option is it's all soft tissue stuff, so the joint itself, if you assume it's healthy and that everything was done correctly there, then you have to assume that it's going to either be some sort of muscular or some sort of, capsular / ligamentous issue. So it kind of depends on what's bothering it. Are there particular things that give him a hard time?
Well, Dave and I kind of talked through this. It was pretty consistent, his pain. And when I initially evaluated him, I assumed, or with the assessment, kind of thought it was coming from his lumbar spine causing his radicular symptoms going down the posterior thigh. And we were talking about how, because there was mobility restrictions in the hip, he was lacking internal-external rotation, lacking extension pretty excessively, that all the movement and mobility was going up into the lumbar spine. And I've seen him for, I think, 2 months now, and I've done a lot on his lumbar spine, and things have gotten better. But I wanted to bring this up and get your thoughts on if there was anything else that could potentially.
Yeah. So you're saying that the posterior thigh symptoms you think are radicular?
I think so. Yeah.
Yeah. Okay. Well, yeah. So that totally changes things, right? So that would tend to kind of suggest the lumbar influence. But you say that the pain is pretty consistent, not continuous, but pretty. It's there all the time. Yeah.
I mean, it has spikes. Like sometimes it'll get worse, but the baseline is consistent pain.
Yeah. Well, and to be honest, that's actually a good thing, because that, if it can be changed with, mechanical movements, body position, any of that sort of stuff, you're thinking it's probably more likely to be something, from a mechanical perspective, as opposed to it being something failing with the replacement, right? Because that pain's going to be that kind of continuous, unrelenting. It's just going to kind of always be there. Yep. So that's good. But what are you doing with the lower back that's been helping?
So I've been doing a lot of mobility, AP glides, and just kind of loosening things up, doing some soft tissue on that area, and some gentle stretching, similarly to what we talked about last week. Just doing some lumbar rotational stretches, seeing if we can take some of the stress off the lumbar spine, decreasing some of the tone.
Good.
Been helpful.
Does he have positive dural testing or neurological testing?
Yeah.
Dural or both?
Both, I think.
Both. You think? Yeah. What were you seeing with the neurologic testing?
So when doing like the straight leg raise, it's reproducing his symptoms, causing that spike. That's pretty much one of the main things I've noticed. Same thing, when I'm doing some of the PA glides on his lumbar spine, it's reproducing symptoms going down into his.
Okay. Yeah, I mean, and that's all pretty confirmatory, right? You start doing straight leg testing or slump testing, and you're just like, oh yeah, this is reproducing this person's discomfort. Right. You're not necessarily, putting any excessive stress on the hip. Now, the straight leg testing for posterior leg pain, it's a tough call, because it could just be the hamstring, right? Mm-hmm. So, I mean, because there is some movement there. Typically, if you're seeing reproduction of symptoms certainly below 30 degrees, but before you get to 30 degrees, that's going to be a pretty inflamed dura. If you start getting them kind of below 50, 60 degrees, then you're looking more at like a dural tension issue, potentially. But if you start getting beyond that, you start getting up into this, 70, 75 degree range, and you're starting to reproduce symptoms there. It's pretty tough to say, is this just a mildly irritated nerve issue, or is this going to be, kind of more of a soft tissue problem, like a hamstring issue, an insertional problem, or even a capsular issue at that point? Because once you get to that point, you're starting to even rotate the pelvis. You're starting to get some movement out of the sacroiliac region and whatnot. So tougher to tell when you get into those ranges. But the PAs on the lumbar spine reproducing it, that's a pretty good sign for me. So if you're looking at it, do you have a level of the spine that you're concerned with? 4, 5.
His L5S1 was kind of the main.
5S1.
And then I was telling, he also had some other symptoms after treatment for like a month. He started having anterior hip pain. And I worked a little higher up on going up into L3, L4 area, and that reproduced some of the anterior and lateral hip pain that he was having after a month of treating him. So I started.
Hey guys, how you doing?
Yeah, and that matches up too. You start thinking L3, you can start getting a little anterior hip pain. That does happen. Did you do any strength testing?
Yeah.
Yeah.
It was because he didn't have any therapy and he didn't do any hip strengthening. He was pretty consistently throughout the hip. And same thing with, lumbar spine, pretty consistently weak kind of throughout with all different directions.
Yeah, I mean, I would say you've got this pretty well covered for the most part. I mean, you've got a couple of positive tests there that tend to suggest the lumbar is the issue. The stress from the hip, obviously going, X number of months without any treatment on the hip in order to regain either, functional strength or mobility through that's going to put a ton of extra pressure on the lower back. Guy in his 60s, probably going to have some lower back breakdown at that age anyway. Yeah. Regardless of whether or not he was any kind of, athlete or, heavy lifter or any type of, day laborer or any had a, physical type job, any of that sort of stuff. So he's going to have some of that to begin with. So yeah, I mean, what would I maybe do differently? I don't know. I mean, at this point, if you're finding stuff that's working, but there's sticking points, if you're finding that, I can't seem to get this motion freed up, you can always try and look at the idea of whether or not your end feels are proper. If you're looking at, trying to work on hip internal rotation in order to help with hip extension, because that's the conjunct movement with things with during gait. You can assess, am I really dealing with a muscular restriction here, or am I dealing with a capsular restriction here? And so you can kind of change your treatment approach a little bit to see if, go from, doing particular for, say a muscular thing, you're to do more stretching, more contract, relax, more strain, counter strain, however you want to describe it, to doing more passive mobilizations, more sustained stretch, that sort of stuff to loosen up some of that inert tissue. So you can play around with the approach there. But to me, it sounds like you have a pretty good handle on what you're seeing there. So, if you have any more specific questions about how to go about doing some things, then feel free.
Okay. Now, I just touched briefly too on the fact that a little bit of 7 and 8 of talking about long leg, short leg concepts after a total hip replacement. And typically what we see there, just that's what you start to think about as well. Is okay, that's when it's good with this material is helpful, because when this individual at some point, like you've already gone up the TL junction on him, which is great. It's just making sure I make my way down to the ankle as well. If he's going to be getting compression up into the lumbar spine, just making sure that, okay, the ankle's moving well, that hasn't gotten stiff or rigid from, not weight bearing on it well. So just kind of come up the chain. What Eric said is exactly right. It's looking at, as we talked about a little bit earlier, extension, internal rotation was probably limited in them. And that's when you start to correct that a bit. You maybe saw some of the anterior hip pain as the counter force of that. And again, we also talked about just as you get into a nominate position in loading L5, that if you did have a functioning long leg, just getting an anterior nominate would drive L5S1 potentially into more extension at that segment. If it was degenerative, as you talked about, it's going to put the stress in there. So it's kind of where it's like, it's nice to look at it from back and front. Like, here's where all the course material applies and everything I'd want to look at in this individual, which you're doing pretty well. And then it's also, okay, don't abandon everything else. I think releasing the front of the hip like you did is perfectly appropriate, whether it's fascial release for restriction or neural input for better, activation or desensitization. I think active release technique is a great peripheral desensitization technique as well. And much like with the manipulation where I'm looking at a neural technique, I look at all my soft tissue techniques and try and think, okay, what am I working and why?
Mm-hmm. What about thoracic spine? Do you guys, because for him specifically, I noticed his whole thoracic spine is super tight with a postural.
Yep, it'd be super tight.
From what we had talked about, like, the thoracic spine, if it's not as mobile as it needs to be in being the rotational force, with walking and functional things.
Yep, it's going to drive forces down.
Yeah, putting it all into the TL junction being a factor in symptoms are.
Absolutely. And one of the things about when you start thinking about that, you just have to consider, because what Dave's talking about with forces coming up from below, you get that anterior nominate and it's going to produce that extension moment at L5-S1. That's essentially a shearing moment, right? So that's the stress that's going through that. You have to consider all three stresses that go through the spine when you're looking at how things are able to tolerate daily activity. So we have shearing is kind of the one that you've been covering, but with dealing with the hip itself and whatnot. The TL junction is going to be more torsion. It's going to be more rotational forces, but can certainly still continue to beat up the L5, going forward, even if you get full hip extension and get good hip internal rotation and ankle dorsiflexion, whatever other limitations you may find in the lower extremity. If you still have a torsional or rotational deficit through the thorax, it's still going to continue to beat up that L5 and it's going to continue to wind that system up. So you're still going to end up with, maybe you don't end up necessarily with, what you consider a pure dural sign, but those chronic lesions that keep kind of circling around, that's where we start to see these facilitatory problems, these facilitations come up. So that can become a problem long term. The other potential stressor is compression. So somebody in their 60s, you're worried less about compression because the disc has probably started to degenerate naturally at this stage anyway. Now you want to make sure that it doesn't, don't start getting any other types of lesions there where you start getting end plate problems, or any of that sort of stuff. So I'm not going to worry too much about a compressive lesion at that point. But, the torsional stuff, you kind of have to look at the thorax because that's where most of that basically the hub of where that's going to occur through the trunk. So, definitely have to look into that and see if that's the case. But that's kind of what we've been talking about, all along with this sort of stuff. You have to think about it from an above and below perspective, right? So, you have these lumbar segments here, and they are designed to take what load they can take, right? They have kind of what we call an adaptive potential. This is what they can adapt to without structural breakdown, right? You start exceeding that adaptive potential, right? You start adding in too much rotation to the lumbar spine in segments with the joints that are straight forward and back, and they're running into each other, and you have the annular fibers of the disc that are resisting those torsions. All the long ligaments of the spine, those are resisting those torsions. You start exceeding what those are usually able to take, that's when things are going to start to break down. People are going to start to develop symptoms, whether it's a referred symptom like what you're seeing now, or whether it's a local symptom. But same thing with those shearing forces. Those things will start pounding away at that stuff, and eventually it'll start to wear out as well. So you got to think about it from that perspective. Here's the area that I'm concerned with. What kind of forces can I get coming from above? What kind of forces can I get coming from below? And if I'm having any of those things, how do I alleviate them? From what you're telling me about your exam process, doing the PAs, reproducing the leg pain, that tends to suggest to me that the lower extremity stuff is going to be the primary driver of the lumbar dysfunction. If you went in and, I don't know, you didn't mention, but if you went in and did a torsion test, a prone torsion test, or even a side-lying kind of rotational stress test to L5, and that was also reproducing it, then absolutely the TL junction is a must, right? But that's the reason that you do those sort of tests during your scanning exam.
You go to PT afterward. Doctor said not to. Then, sorry.
Oh, you're not talking to us. So the idea would be is, if you can isolate which stressor is reproducing the discomfort most substantially, then you kind of have your answer, right? You know, if the PAs are really doing it, lower extremities probably doing that because that's going to cause more of that extension moment.
Mm-hmm.
If rotational stuff, the torsion test is really reproducing it, probably more TL junction. If you're getting it on both, then you got to deal with both. Does that make sense?
Yeah, it does, for sure.
Yeah.
I guess
so,
when I was going through the scanning exam, I didn't really break it down that much with like the torsion test and seeing if it's, you know, more of just that, you know, anterior posterior force that's causing it, or kind of
yeah, and to be honest, that's a perfectly good screening exam, right? So, you know, we talk about the difference between a scanning exam, which where you're running through multiple tests and, you know, kind of looking at things from different perspectives. The biomechanical exam is where you're really going in and you're doing all your individual tests on different segments or different components of a joint region, any of that sort of stuff. And then these screening exams are really, they're just these short, quick run through tests that you can do to rule in an area or rule out an area. You know, like we were saying with the elbow quadrants are a great thing to do to see if you potentially have to go and examine the elbow.
Mm-hmm.
Quadrants are a great one for the hip as well, right? So those PAs, that's probably the number one test that you can do for the lumbar spine to see if it's provocative and see if you need to go in and do a full exam there. Now, like I said, typically you have to be able to check for all three different types of lesions, whether it's a compressive, shearing, or rotational lesion, and kind of rule those in because that can guide your treatment, right? So it'd be a good idea at some point to go in and check that out on him just to see if you have something there.
Cool. Also, another question that comes up is I had to kind of explain to him why I was kind of working my way up to the lumbar spine because he didn't have any pain up there.
Sure.
Since surgery. So I was just curious, do you guys see that pretty frequently? Have people having some of this ridiculous symptoms or issues coming and originating from their lower back, but they don't actually have localized pain?
Yeah, I mean, it happens all the time. You get somebody that comes in and it's just, you're looking at what their problem is and you just start getting this suspicion that this is not just a local problem, that there is some descending influence from the from a spinal segment. You know, the one that I tend to see the most often is going to be, actually it's in the upper extremity, but like a lateral elbow pain, where you have somebody come in and you're looking at the elbow and you're going through all these tests and you're just like, I don't see a damn thing here from a local perspective. And at that point, you have to basically tell them like, look, we're going to have to look elsewhere because all of the tests we're doing for this particular area are coming up clean. So we have to assume now that this pain is originating from someplace else. And the thing that I like to be able to do with cases like that is I like to be able to show them something specific that I can predict ahead of time that'll tell them like, this is what I expect to see. This is the test I'm going to do. This is the result I expect to get out of it. And then when I can show them that that's the case, it usually makes them think, okay, well, that makes a lot of sense. So for me, with you know, whether it's radicular stuff or facilitation stuff, it's strength testing for me, where I can say like, look, I'm going to test these couple of areas of the body for strength deficits. And if I see this particular type of deficit, whether it's a velocity dependent type of deficit for facilitation or a fatiguing deficit for a radiculopathy, I can tell them that ahead of time and say, look, this is what I expect to see. And then when you show it to them, they say, okay, well, you know, how do you change that? You can do like with a facilitation, you go in and just do a little wobble at the segment, something of that nature, retest it, and you just say, see the input here. I did nothing else other than affect this spinal segment, and it changed this response, right? So usually that's enough for me to convince a patient, okay, we got to go in this other direction. The hard part in your situation here is that they had surgery on the area in question, right? So obviously they're having some limitations there. But you can still use those same principles. You just have to qualify it a little bit more by saying, look, it's not just the hip that's having these deficits. You can go down and you can show them some weaknesses in the ankle, around the knee, any of those sort of areas to say, look, you know, this is why I think it's more of a centralized lesion here, because we're having problems in the hip, we're having problems around the knee, we're having problems around the ankle or into the foot. This can't just be a local hip lesion that's causing that. It has to be something coming from above, something that's controlling more muscle area, more tissue mass than what you're seeing just around the hip. That makes sense?
It does.
Dave, how do you go about that sort of stuff?
Yeah, no, I think you're spot on. I mean, it's pretty consistent with what I do and kind of how I see it. One thing Eric did remind me of that I didn't talk about when I think about rehabbing this individual, we talk about rotary and compressive forces, then rehabbing in those realms, as it were. So this individual in my clinic, basically a lot of my exercises would also be geared toward ankle and hip and TL junction rotary moments. Because what you're probably seeing is that he's probably lacking the ability to motor control internal rotation on this hip. So he's gonna start stealing it from other places. If he doesn't have his ankle and his hip, excuse me, SI joint lumbar spine is the next segment up. So am I beating up these other segments by basically I didn't relearn how to internally rotate on my hip, especially a 60-year-old who may be active and he's golfing, and now becomes a big problem because he needs to be able to spin on that hip, and he's now got a nice new shiny metal hip that he can spin on. So I would usually teach them basically the pronation supination with rotation. I look at that and I come up and make sure they have it from the hip, and that starts to unload the lumbar spine. So even in lumbar spine patients, it's pretty typical that I'll make sure that they're able to kind of move through these rotary joints appropriately and do well. So whether it's first just in rotation tests, and then it's either with bands usually I'll do, or free weights, and I let them feel how, wow, I get no rotation from these other joints when I do it this way, and I move in that pattern. Conversely, the case I had for today, which is it's nice to do your case, so I'd rather do that. But it's a similar thing where she's getting buttocks pain, but she's finding with the driving extension moment of the lumbar spine. It's when she takes her right facet and drives it into extension, and she gets the buttocks pain. So one of the things you can do is by improving her, basically the first part of her extension moment and standing extensions, her hips need to go forward. She was taking it all from the lumbar spine without any hip motion. So I always want to know, can I balance that pain pattern with motion at another joint? Because that is my easiest fix for anything. So whenever I see somebody, boy, that's what I'm hoping for. I'm hoping for that there's a deficit like in this individual where it's like, oh yeah, he's not moving through the hip or the ankle well enough, and he's trying to play golf. That's an easy fix. Whether I need to either work the motor pattern, neural control, is it a joint I need to it's restricted and I need to improve that joint's restriction? That's what I want to find. So in this individual, for the rotary pattern that Eric talked about, I would definitely think about that. And that's where you get into TL junction and in thoracic spine. Now you have to work up into the thoracic spine. And I usually talk about, look at the thoracic spine as like upper and lower. At some point, he'll probably get enough motion through his TL junction or get some motion through it because he's probably fixed and kyphotic in his mid-thoracic spine. So he's going to hinge above it and he's going to hinge below it. So how do I maximize my mobility out of the thoracic spine to decrease those compressive and rotary forces? So he may need to learn ankle, hip rotation, probably going to have to learn how to use his upper thoracic spine as scapulas to drive thoracic rotation from top down as well. And you find that this person will be limited in that because of the limited thoracic mobility. He will not have the thoracic mobility of a 24-year-old yoga instructor. You will not get him the thoracic mobility of a 24-year-old yoga instructor. What you will do is you'll improve his upper thoracic mobility by 25%. Okay, and that'll be significant for him. So that's kind of what I see in the 60-some-year-olds that you can do. And that segment's still mobile, it's just making them to move through it.
Yeah, I mean, essentially with stuff like that with golf, you're looking at where else can I add any motion into this rotational component, so the TL junction's a huge one, but that upper thoracic is just as big, even getting into the shoulders themselves, because if you can't get good cross adduction on one particular side because of an AC joint restriction or posterior capsular lesion, the only thing that they're going to be able to do is they get to this point where that structure will lock up is they have to turn through the trunk. Right. Similarly with the neck, if they can't get their chin down to their shoulder when they're trying to keep their eye on the ball before going through into their motion, or conversely, as they're finishing their motion there on the opposite side, they're going to shorten their stroke, and so they're going to lose distance. They're going to lose accuracy. It's just going to be, they're going to get frustrated with stuff like that. So, if you're looking at a person from a task perspective, something like golf, because it is a total body movement, right? It's an interactive thing that goes from head to toe, basically. you got to kind of take some of those things into consideration. And you prioritize the areas, right? So, I mean, if they're having hip problems, you prioritize that TL junction, you prioritize the hip, you prioritize the ankle. But if they're still coming back and they're saying like, yeah, I'm fine when I walk, I can do stairs, I can, deal with my dog and do my yard work and all that stuff. But when I go golfing, things are still pretty sore the next day. Okay, well, show me your golf swing. Show me what you can get to. And you start looking at it, you're just like, Jesus, for number one, your neck doesn't move enough. You only get 45 degrees of rotation there, so you're shortening things up, adding more motion into other parts of the body. Or hey, your shoulders are real stiff. That upper thoracic area isn't moving well enough. So you got to take it from a task perspective, right? That's that. Dave probably has talked about this in the past, at least with some of you guys, but Diane Lee calls it the meaningful task. I think she calls it. Is that right, Dave? Mm-hmm. And the way she does it is she'll put it on a piece of paper with the meaningful task right in the center, right? And it's just, this is what they're trying to do. And then the problems and everything kind of expand from there. But you always have to come back to that center point. This is what this person wants to be able to do. So from a rehab perspective, that may change some of the approaches you take, right? You may spend more time with them doing mobility stuff at home, and some neuromuscular control stuff as opposed to doing pure strengthening stuff, because in those cases, they need to be flexible. They don't need to be, super strong and powerful, I guess would be the term. They don't have to build up significant hypertrophy of any particular muscle groups. They just need everything to move enough to get through the motion without hurting themselves. Mm-hmm. So you change your priorities with their home tasks as well.
Makes sense.
Is that one of the things that he was doing? Is he wanted to play golf, or are we just making that up?
I think I made that up.
Yeah. Well, even still.
Talk about, because we, in the area that I live in, Chicago, there's a lot of golfers.
Sure.
That come in and out, and there's golf ranges everywhere, so it's helpful to know and talk about.
It's a non-obvious thing. It's getting dressed. It's doing those other tasks, and where he's pulling his rotation or his mobility from, because he spends a significant amount of time moving around that hip. That's kind of where the surgeons feel like, you know what, post-surgically, yeah, they're going to get back to a baseline, but the little things don't get cleaned up when they don't come to rehab. And those are one of the things I consider as being important, is learning how to kind of move now that you've had altered movement pattern for, months or years to that point.
Well, I can't get behind the, you don't need rehab post, total joint replacement. I know a lot of docs are throwing that out there nowadays with the like, oh no, just walk, you'll be fine. That'll be plenty. It's just like, no, you know what? You need some guidance here, because, even in your 60s, people that are active, they want to be able to do things. They don't want to just be able to get around the block, go to the grocery store. They're not just all sitting in rocking chairs on their front porches all day. That's not how people want to be nowadays. I mean, coming from Denver, most people here are super active. So it's kind of, maybe I'm looking at it from a, mile high colored glasses, but at the same time, I tend to think that's just the way the world's going. People want to stay active longer. It's a good thing, but the idea that you can just kind of walk it off, it's a little short-sighted to me.
Some of the surgeons saying that after a total joint replacement nowadays, because this is the first experience I've had where the doc was just like, no, don't do rehab, just do stuff on your own.
No, I think it's much more common.
Oh, really?
Yeah, there's a lot of docs around here that are kind of throwing that out there. And I had a few patients of mine that, that I'd already been seeing that had to go in for a knee replacement or had to go in for a hip replacement or something. And the doc told them that, like, well, you don't need PT, you'll be fine. And it's just, they actually tell the doctor, like, no, I've got a guy and I'm going to go to him. So just go ahead and put pen to paper here and, send me on my way. But usually those are the people that are telling me, like, I want to be able to get back to skiing, or I want to be able to ride my bike on the weekends. And it's just like, okay, well, you need to have something specific in place here, because you can't just walk it off and then decide you're going to do a different activity. Walking it off, maybe you get back to doing well enough with just walking. But if you want to do something else, something additional, you got to actually have somebody that kind of can help you with the mechanical components, can help you with the strength components, can help you with the control components, all that sort of stuff. So yeah, that's a tough one when docs decide that it's not necessary.
We have a couple of docs that now for knee and hip replacements are giving them an app on the phone for exercises to do.
I can see that.
You know, I have some.
But-
I have
But
some
to play off
patients-
of what Eric had mentioned, like if they did just walk, like they're like you said with the compensatory movements that they're gonna have pain elsewhere. They're gonna have back pain, and they're gonna think, well, I can just battle through it. And like you said, if we don't get them moving better, it's gonna continue to get worse.
Yeah, and the worst part about that is sometimes it doesn't kick in for 3, 4, 6 months after the fact. You know, so you have somebody that's like Chris's patient that's a hip replacement, and they say just walk up, just walk every day, do increase your amount of steps and all this sort of stuff, and they do fine. And then 6 months down the road, they start developing glute pain, or they start developing lower back pain, or mid thoracic pain, or any number of other areas where they start developing discomfort, anterior knee pain. Who knows? And it's all caused because they didn't deal with the problems that they had post surgery, but they don't know that because now it's far enough removed. They think that they're recovered from that surgery, even if they never really were, because how would they know? They're not trained to see where problems are coming from. So yeah, it's tough, but
Yeah, there's been 1 or 2 studies published on, just conservative rehab, not doing PT and for knee replacements and total hip replacements. I think they were done in Australia, which showed that, these patients did just as fine or as good as people went to PT. So it's all on what you want to hang on. When you're the surgeon, your surgery looks better when you don't need to go to PT.
Mm-hmm. Sure.
It's a selling point for that point. Like, hey, my surgery was so good. So it's all in, perspectives and how we see it. And there's an article to support whatever you want to do anywhere. If you just grab one article and read one article. So, given that one, they kind of run with it, and especially with the anterior hip replacements. Like, oh, you go to the hospital same day, and oh, you don't need PT, so it saves in healthcare costs. So it's sold all different ways in that, but there's moving well, and then there's just, okay, I'm done with you in 4 hours type of thing.
yeah, it's a lazy idea. It's just, they're trying to promote the idea that the medical side is what needs to fix things, and it's not the rehab side. And I don't know why they bother doing that. It's not costing them anything extra to send a patient to PT. But maybe that's how they sell these patients on getting these surgeries in the first place. It's just like, well, I don't feel like, I don't want to do 3 months of rehab after having this done. It's like, well, you don't have to. You can just walk it off. It'll work just fine. Like, oh, okay. Well, in that case, sign me up. I can't imagine any other reason that docs would decide that this is suddenly, after decades of, requiring rehab after surgeries. I'm sure that their appliances, their prostheses and all that sort of stuff are getting more efficient and whatnot, but doesn't account for the rest of the body, so it doesn't account for, what the soft tissue is going to do around it, doesn't account for how the muscles are going to recover. Doesn't account for things like gait patterns, which are infinitely compensatory. There's always going to be some adaptation that occurs with gait patterns if something's not working properly. So it's yeah, I don't know. It's my soapbox on that sort of stuff.
I did have kind of an interesting SI joint patient come in last week, and I just got to see her the second time. Her script basically just said rheumatoid arthritis, and I had to ask her, okay, what body part are we working on? And she said, well, my doctor thinks it's sciatica, but it feels different than when I had that before. And she literally points to left PSIS. So right away I know, okay, positive for RA. It was a little tender there. She really only complains about walking or standing. No pain rolling over in bed. She does a left step 2 for stairs when she does have to do them anyway, but it's always been because of her knee, even before this pain started. But it sounds like this has been going on for a while. She does infusions for her RA, and she can tell when it's time to get that because all of her other symptoms are coming back, and her pain comes back. It hasn't touched this back pain. It's separate from that. And it's really mild, like it wasn't like a hot joint at all. So it was very minimal tenderness when I'm there. But her gait was very stiff through that hip. So she's lacking a lot of extension. And when I first was doing prone hip extension, just even look at it compared with her right one, there was nothing. And just a little bit of soft mobilizations in there. We got it equal to the right hip before she left that day, and she walked out without a limp. And then today I saw her and she said, now walking is still pretty much the same. Her primary stress tests were negative. I couldn't get anything with compression or distraction, didn't reproduce any of her pain. And so I was like, I really don't think that this is true sacroiliitis. It seems like it's more of a mechanical issue because it wasn't painful hip extension. Her stiff hip, and now that we're saying, no, she's probably extending from that L5 over that S1 in order to get her extension during gait and in standing. And so today I worked a little bit more on her hip. Let's see. Stoddard, I didn't find anything. Forward bend, that left one seems a little bit stiffer. It goes forward. She had a little bit of pulling. She described as pain with left side bend, left rotation, and that was it. Otherwise, not much reproduced it. Her strength, I was actually surprised at. No tenderness palpation through the glute, not at ischial tuberosity, not sacrotuberous. So I kind of tried to check all of those things. And when I look at her, what's the other name for stork test? Gillette?
Gillette.
Forward bend. So Gillette, that's where I feel like she's not able to transfer the load on that left SI joint. So we worked at that today, got her left hip moving. I did, today she was actually left innominate anteriorly rotated, and that left leg looks a little bit longer. And I did a muscle energy, and that innominates looked better. Left leg's still a little bit long. Mobed left hip, a lot of posterior mobes, and then some PAs in prone. Her hip extension is still a lot better than initially last week. And then we did a bunch of pelvic tilt mobility, some TA, and then I got her up and sitting. We did pelvic clocks on the stability ball, did some marching on the stability ball with TA, and then I had her tap a step, and I watched, and she did a lot better for 10 reps at that left SI, and it looked symmetrical. So I was just kind of surprised. I was like, oh, ding, positive for RA autoimmune, and then I was like, this is acting more mechanical.
Well, it doesn't. I mean, here's the deal with a autoimmune condition like an RA. It just because that's one of the major risk factors for destabilizing the sacroiliac joint doesn't mean that it has. And what they would tend to report is they would have had to report probably multiple episodes of sacroiliitis over their lifetime in that area for it to destabilize an SI joint. Because it's the inflammation that chews up that interosseous ligament. So if they haven't had a real significant sacroiliitis, and certainly if you're not testing positive for one, then I wouldn't suspect that it's actually destabilized that thing. Now, here's the problem is it doesn't have to be structurally destabilized to be functionally unstable. So what that means is, and this goes back to what Dave and I have been talking about quite a bit with the SI joint, is that nutation of the sacrum still has to occur, even in a perfectly functioning 25-year-old with no inflammatory conditions. That still has to happen. That relative forward motion of the sacral base against the innominate still has to happen to make it stable. So let me ask you this. Did you said it was tender over the PSIS, correct?
Yeah, like that Fortin's point.
Yep. Did you move down the sacroiliac line to test for tenderness down
Yeah. She's not tender anywhere but right at that point.
So here's what I would think is actually the problem. My suspicion is the tenderness at the PSIS is actually an insertional tendonitis of the iliocostalis.
Okay.
So her driving lesion that's actually causing the discomfort when she's walking isn't the SI joints, probably, and the hip's probably not helping things, but it's probably a mid to lower thoracic lesion that's causing the problem.
Okay. So mid to lower thoracic, which I didn't look at that yet, but getting the hip as good as I did with one treatment and that maintaining really well, I think that's what I'm going to look at next time, is looking up.
Yep.
So another torsional, basically because it's that torsion, you're looking so that it's more on left base, basically being a little bit more extended. So when does that iliocostalis, when is that going to be, like, how is she compensating with it functionally, basically?
How old is she?
60, let me double check.
60s is good. Okay. Good.
So,
Eric.
so what
She
we,
is 66.
yeah. So, I mean, what we're seeing with the iliocostalis is it's not necessarily a compensation as it is an increase in resting tension.
Okay.
Right? So what we see is with the thoracic ring, right, we have the ring going around the trunk. If you get some sort of deviation of that ring, right, a lateral deviation of one of the rings, or even just a rib lesion, something like that, or even a facet lesion, what it does is that posterior portion of the ring here, so on her left side, right, so that would be her left side here, if this goes up like that, right, say a flexion subluxation of a facet, or a left deviation there, that's going to roll that rib forward. It's just going to take that attachment point of the iliocostalis on the costal angle there, and it's going to pull it up like that.
Right.
And so all we've done then is we've pulled tight that muscle that needs a little bit of slack, right? And so the only other place that you're going to develop problems there is probably in the swing phase, so that just before heel strike, on the left side, as that innominate tries to rotate posteriorly, right? As that heel swings forward, you're going to put an extra increase in tension on that iliocostalis, and the only place you're going to feel it is right where the muscle attaches, right? Because if it was a mechanical sacroiliac discomfort, you would have discomfort down the line of the sacroiliac joint. You'd probably be able to find tenderness along at least one of the ischial tuberosities, sacrotuberous ligament, any of those sort of things. You would definitely have, more consistent weakness around the hip that would be associated. Jim calls it a reflexive weakness. I tend to call it a regional weakness when you're dealing with a girdle, like the pelvic girdle or the shoulder girdle.
Right.
So you're going to get significant weakness around the hip, but it's going to be because you have a poor anchor around the pelvis now, right? So
and I definitely didn't see that. I'd expected to, and I didn't see that.
And you didn't. Yeah. So, I mean, when you start thinking about that and it starts, some of the ideas that you have and the things that you would predict aren't coming up as positive, you got to just look at it from another perspective, right? And so this is probably the most common cause. Well, tough to call that, but it's at least in the 50-50 range with a long leg on the one side. So a stiff hip or a stiff ankle, something of that nature, that's going to cause these sacroiliac things. But it looks like the sacroiliac's holding up okay. It's just you're getting kind of this, you'd almost call it like a pseudo sacroiliac pain, because it's not truly the sacroiliac joint itself, but it's just right around that sort of thing.
Yeah.
So it's a, just another way of looking at things. But that'd be what I would do.
Yeah.
I'd just go in and I'd look at, first thing I'd just say, okay, arms up here, turn to the left. Okay, that's not very good. Turn to the right. Oh, that's significantly more motion. That's what I would expect to see. She'd be stiff going to the left. She'd be more freed up going to the right. And that's where you're going to get some of these things kind of. You can palpate up the line of the iliocostalis as well, and it'll be tender.
Yeah, I bet she probably has some type of rotoscoliosis going on as well. She's had rheumatoid arthritis for a while, so you're going to find a hypertrophy on the one side of the iliocostalis and atrophy on the other. So I'm betting
that makes sense, because she's actually been saying that when it gets aggravated, it feels like it goes up her spine. Because I was saying, does it go down towards your tailbone? Does it come around the hip? She said, no, it goes up into my
Yeah.
back.
That's
Yeah.
pretty common to find with that, is that if they've had it
Yeah.
for a long period of time, they'll start to develop a rotoscoliosis. And then
Okay.
you'll certainly see it with that. One side will all be atrophied. The concave side will be atrophied. The convex side is usually hypertrophied, which will then kind of, she's stabilizing from there, which is the exact point that Eric's is talking about. What's nice about
Yeah.
this, Eric, is we look at things quite differently, but we kind of end up the same, which is kind of a nice thing. But
Yeah.
yeah, that makes good sense. My mother had bad rheumatoid arthritis for probably since her 40s till her, till she passed away in her 70s. And it was funny. The one thing she could really tolerate well, and hers was bad, is she had a terrible rotoscoliosis. And when I would needle her because it worked the best for her because it was the least intrusive. I'd mobilize ribs and needle, and she did really well with that for pain-wise, even in these areas. And it's kind of that same premise of treatment. But what I did was I carefully palpated each rib and each spinal segment, because the atrophy on the one side was, it's a very deep gutter. The other side was very well developed. So I want to make sure I knew where every needle went. So I just didn't kind of blindly needle the pair of spinals in her.
Mhm.
And I knew the depth, I knew the rotation, and matched my angle for each segment. So if you do get into doing something like that, there's one thing I would recommend is that, just check her spine out with extra care and approach each segment as if it's its own. But you'll probably also find out what Eric was talking about, driving that spot. I think it still could be a little bit of L5S1 irritation referring down, but I definitely think you need to clean up what Eric's talking about, because I think, as he said, 50-50, it's probably a good 50% chance. It's probably what Eric's talking about is contributing to it.
Yeah.
Yeah, there's definitely a good chance that she's got an irritated L5S1. I mean, she did just have some SI joint pain, so she's probably limiting her stride length on that side anyway, because it's probably not terribly comfortable. Even just, you said, even just weight bearing, just standing on the one side was painful as well. So I think that makes a lot of sense that she's gonna have to take up that stress somewhere. So it's probably going to be L5.
Right.
I wouldn't suspect that to be the driving factor. If you went in and just treated L5S1, I think she'd still have that same point.
Yeah,
Yeah, that makes sense. Yeah, she was diagnosed when she was 26.
Oh yeah.
So she's had this a while, so I'm sure there's a lot of compensations up the chain.
Probably.
You gotta get out of
Do
here,
this
guys.
well.
Thanks for
You
the-
tell her that
Hi, Chris.
she may be coming back to see you every couple months.
Sorry, say that again, Dave.
She may be coming back to see you every couple months just to get needled or treated or symptoms that fade in their back for this or something else.
Yeah.
She's a good
I do
life
not do
coach.
needling, but
Okay.
I know a few people that do.
Yeah, just release it.
Yeah, you
Yeah.
could just do a soft tissue thing. Just pressure release works pretty close to the same.
Cool.
Or mold the ribs. That's also a great technique. The
Right.
rib glides. It's a good mode for these arthritic patients.
Yes.
Mm-hmm.
Specificity.
Just be
Yep.
careful not to get too wide on the rib.
Yeah, good point.
Don't get too far out on somebody in their mid 60s, female in their mid 60s.
Mm-hmm.
You don't want to put too much torque through the shaft of a rib, because if she's osteoporotic or osteopenic, it could be bad news. So stay as close to the joint line as